Доброго дня, шановні колеги. Я бачу, що потрохи під'єднуються учасники та
Good
слухачі
afternoon, dear
вебінару.
colleagues. I see that
На
the
жаль, через певні
participants
технічні
of the
проблеми
webinar
не
are
можу
joining
включити
us.
камеру. Сподіваюся,
Unfortunately,
що ви
for some
мене
technical
добре
reasons,
бачите
I
та чуєте.
can't
Будь ласка,
turn
дайте
my
знати
camera
в
on.
чат, чи добре мене
I
чутно.
hope you can hear me. If you could write in the chat that you can hear me, please. And people write,
Чудово, я
yes, we
бачу, що
can.
мене всі
Great.
добре чують.
I see that
Я
everybody can
розумію, що
hear me
потрібен
well.
певний час,
I
щоб
understand that
учасники
it requires certain time
під'єднувалися.
for
Я
the
дуже
participants
вибачаюсь за
to
певні
get
технічні
connected.
моменти.
I'm sorry for certain technical
І
issues.
через декілька хвилин
And
ми
in a
будемо
few
вкотре
minutes,
починати.
we will be starting.
Я бачу, що кількість учасників стає більш-менш
I see
стабільною.
that the number of
Постійно
the
чекаємо
participants becomes more or
долучення
less
інших
steady.
наших колег,
We're still
але ми вже
waiting
будемо
while other
починати.
colleagues join us,
Нагадую,
but
що ви
meanwhile,
на
we're going to
вебінарі Центру
start.
громадського
Let me
здоров'я,
remind you
який
that you're at the webinar
організовано за
of the
підтримки
Ukrainian
наших
Public Health
донор-партнерів.
Center, organized
Вебінар
under
щодо
support of our
профілактики
partners.
інфекцій в області хірургічного
This
втручання,
webinar is about
асоційованої з
um,
імплантами при лікуванні больової
implant-associated
травми.
SSIs
Сьогоднішній
and
вебінар
about
є
the treatment of
продовженням
combat
циклу
trauma. Today's
лекцій,
webinar is
яке
the
відбувалося
continuation of the
весни
series of
і буде
lectures
знову ж таки
which
продовжуватися
have
і
been
далі.
taken place
Цикл
during
вебінарів
this year,
«Європейський
and we're
досвід
going to
впровадження
continue.
інфекційного контролю та
This is about
лікування
European
антимікробних
experience
препаратів,
of
шкідливих
introduction of
для
infection
переїду».
control
Цей
and
цикл вебінарів
antimicrobial
створено та
stewardship.
організовано
This
за
series of
фінансування Центру
webinars
контролю
was
та
created and
профілактики хвороб
organized
США
at the
CDC
expense of
та за
US
підтримки
CDC
ICAP
and
Колумбійського
under support
університету. І
of
спікерами цього
ICAP,
вебінару
Columbia
є
University. And
досвідчені
the
лікарі,
speakers of this
експерти,
webinar are
професори,
experienced
що викладають
physicians,
в
experts,
різних медичних
professors
університетах з різних куточків
who
Європи
lecture
та
in
є
various
членами
medical
Європейського
universities
комітету з
across Europe
інфекційного контролю
and who are members of
організації
European Committee on
КІК.
Infection
Як завжди,
Control,
у нас буде
UKIC.
можливість після
As
презентації
always,
лектора
we will have an
задати
opportunity after the
питання,
presentation
наскільки
to
нам
ask
важливо час, тому що, на жаль,
questions
ми
to our
дещо
lecturer.
затрималися з технічних моментів.
For
Для
technical
того, щоб
reasons,
задати
we are
питання, будь
slightly
ласка,
delayed. But
запишіть
if you want to ask your
напишіть
question,
їх
please
у чат.
write your
Є
question in the
окремий
chat box.
розділ Q&A
Also,
без
there is
інтернеті,
Q&A
де ви можете задати
tab
своє
where you can
питання.
ask your
Ця
questions.
зустріч буде
This
тривати
meeting
60 хвилин.
will last for
Після
60
зустрічі буде
minutes.
сесія
After the
питань
meeting, we're going to
відповідей.
have Q&A session.
Також нагадую, що на
And let
зустрічі
me remind you
передбачено синхронний переклад,
that we
який
have
потрібно
simultaneous
попередньо включити в
interpretation
налаштуваннях
here.
Zoom. Для цього
You need
потрібно
to do some
натиснути на
tuning
іконку
your Zoom.
планети
You need
і
to press
обрати
a globe-shaped
українську мову. Таким
button,
чином ви
select
будете
Ukrainian,
чути
and in such
повний
a way you'll
переклад.
be able to hear
Лекція буде
simultaneous
записана
interpretation.
та
The lecture will
викладена
be
у відкритий
recorded
доступ на YouTube
and
каналі Центру громадського здоров'я
published in the open
ВОЗ
access
України. Знову ж
on
таки, ми
the
працюємо щодо
UPHC
технічного моменту.
website. With
Сподіваємося,
regard to
запис буде
technical things,
успішно
we hope
виконано.
that the recording will be fine.
Також, знову ж таки, нагадую
Also,
про
let me
те,
remind
щоб ви
you
слідкували за анонсами
to
офіційних
follow the
ресурсів Центру громадського
announcements of
здоров'я
the
та
official resources of
підготувалися
Ukrainian Public
до
Health
самих
Center
лекцій
so
цього
that you could join
вебінару,
upcoming
цього
lectures
циклу
of
вебінарів.
this
І також щоб ви
series of
могли, як завжди,
webinars,
передивитися попередні
and
записані
also for you to
вебінари
be able to
з викладачами,
view again the
професорами
previous
організації
webinars
КІК, які є на
with
YouTube-каналі
the
Центру громадського
lectures
здоров'я.
from EU KIC
Отож,
available on
не
the UPHC
затримуючись далі, я
website.
хочу
With no further delay,
передати
I would like
слово
to give the floor
нашому
to
сьогоднішньому
our
спікеру,
today's
професору
speaker,
Штефану
Professor
Вестенбройху з
Stefan
Громадського
Ruslan Broik from Münster University, who is the executive consultant of the Department of Trauma and Reconstructive Surgery, and who has a vast experience in this area. And today's subject of today's presentation is prevention of implant-associated SSIs and treatment of combat trauma. Over to you, Professor.
Yes, so thank you so much for giving me the opportunity to be part of this program. It's a great honor to show our solidarity with the Ukrainian people. So I'm really happy to be part of this program and to talk about prevention of surgical site infections associated with implants in the treatment of combat trauma. Just a short introduction from our side. I'm currently working in Münster. It's a university town in the northwestern part of Germany. It's about 300,000 inhabitants. Most of the time, it's 65 students, and it's supposed to be the capital of bicycles. So we have more bicycles in Germany, in Münster, than we have inhabitants. So next slide, please. So currently I'm working at the University Hospital Münster. There's some numbers about our hospital. We are taking care of the northwestern part of Germany. Our focus, next slide, please. Our focus is on oncology, inflammation, transplantation medicine, robotic surgery, cardiovascular, neurological diseases, but also psychosocial medicine, parent-child, adolescent medicine, and musculoskeletal medicine, where I come into place. Next slide, please. So this is our department of trauma, hand, and reconstructive surgery. Right in the middle, the guy with the green shoes, that's me. Since the video is not working, and two persons to the left, it's my head of department, Mike Rashke. Within this department, as I said, we are taking care of northwestern part of Germany, especially, next slide, please. Especially if we are talking about complex situations. We are helping within this project called Expert, and within our region, which we are responsible for, we are providing multidisciplinary support for 32 hospitals, especially into concerning complex injuries, open fractures, fracture-related infections, non-unions, and postoperative complications. And since there are several patients from the Ukraine within the Solidarity Cooperation from Germany and Ukraine treated in Germany, a lot of these patients are presented in this multidisciplinary board. And by that, and also, next page, next slide, please. And also by the official town partnership of Münster with our partnership in Venezia. We have a strong cooperation with the hospital number one, exchanging cases, talking about the way to treat our patients. I know the nurses and doctors, the whole medical staff is doing a tremendous job in the Ukraine, taking care of a lot of complex situations. And we in Münster are really learning a lot from our colleagues in Venezia by talking about different cases and sharing experience. So this was sort of the starting of our cooperation. And now to our topic of today. Next slide, please. If we are talking about prevention of surgical site infections associated with implants, it's predominantly that we are talking about fracture-related infections. And especially if we are talking about infections to the bone. Next slide, please. It's defined as an inflammatory process accompanied by bone destruction and caused by an infecting microorganism. Next slide, please. But we know that it's not always so clear to, let's say, identify infect, or is it just a wound healing problem? Is it just a hematoma? So it's important to define the terms we are talking about. The terminology is really, really important. So there has been work been done on this topic, and especially talking about surgical site infection associated with implants in trauma. The term, next slide, please. The term of fracture-related infections is of utmost importance that we all know what we are talking about. Next slide, please. So there was great work on defining this term of fracture-related infection by Willem Metzemakers et al. In this publication. If we talk about FRIs, there are confirmatory signs like a fistula, a sinus, a wound breakdown, purulent drainage, and by then we know it's defined as a fracture-related infection. Next slide. If we, sorry, go back once more. Yeah. If we are talking about, if we're not sure, we're talking about suggestive signs, clinical signs, radiological signs, inflammatory markers, and new onset drainage. And if we have these suggestive signs, we need to do surgical exploration. We have to get pathogens from the deep tissue to define if there's a fracture-related infection. Because we have to know if we are talking about patients. Next slide, please. Like this young patient born in 99 was a African a patient who was treated in our department. His history is a bit unclear, but he sustained his injuries in a civil war or in a conflict area in Africa. He had multiple surgeries and he presented with pain, fistula, osseous destruction, as you can see here. So, next slide, please. So we had to perform a segment resection. You can see on the left-hand side the resected bone with the integrated antibiotic beans, which have been implanted for a lot of years and did not provide any antibiotics anymore, but worked as a foreign body, supporting the infection. So we found Staphylococcus aureus. We resected the bone, placed a spacer. Next slide, please. And then we had to reconstruct the defect by performing a callus distraction. Since the plastic situation was highly complicated, it was not really easy to place a free flap in this situation. So we used the ring fixator, which you can see there, also providing a soft tissue transport, not only a bone transport. Next slide, please. There is several ways to do so. Next one, please. So it's either a bifocal one, next one, where you can have two proximal osteotomies and you can transport them 1 millimeter a day towards the docking zone. Next one, please. Or you can have a trifocal one where you have osteotomy at the bottom and the top, and you could narrow these two segments. Next one, please. By double the speed to have the bone transport, but also in this case, also the soft tissue transport. So those are the X-rays the following weeks. You can see the osteotomy side, you can see the soft tissue side. Next one, please. Next one. And you can see that the wound is sort of closing. The gap is getting smaller. Next one, please. And next one. There the skin was invaginated and we had to surgically remove that. But more and more the transport was docked, the gap was bridged. Next one, please. And after the docking zone, we implanted an antibiotic nail. And as you can see, the patient was able to move. We have another CT scan where we see a bony consolidation. Next one, please. And what I wanted to highlight with this case is that debridement, especially in treatment, but also in prophylaxis, is essential if we are talking about fracture-related infections. Next slide, please. So if we're talking about prevention of fracture-related infection in combat injuries, there are special considerations we have to talk about. It's predominantly a high energy, high lethality of the injury agents. There are multiple causes of wounding. There's a predominance of penetrating injuries. Most of the times, the threat is persisting in tactical settings. It's an austere, resource constrained environment. These injuries are happening, and often the access to definite care is delayed. And we are talking about various microbiologic spectrum. Next slide, please. Especially the high energy, the penetrating injury, and the delayed access with various microbiologic spectrum is making the treatment of these combat-related injuries highly challenging. Next slide, please. So in the next slides, I would like to talk about the epidemiology, give you some numbers. We are going to talk about classification, risk factors, and the keystones in prophylaxis. Next slide, please. So this is a paper from the United States Forces and the UK Forces, where they tried to go through the decades and looked at the ways wounding and combat related situations happened. So they see these authors stated that there is a shift to fragment injuries in modern warfare, and it's in 62% fragment injuries we are talking about. That's mostly the soft tissued injured, but in 1/4 of the combat related injuries, we are talking about fractures to the extremity. Next slide, please. Sorry, go back again. Okay, so one more, go back, please. Okay, there we go. So, and it's mostly of the lower extremity. Next one, please. So if we're talking about combat-related injuries, it's predominantly a high velocity open fractures, which we are dealing with. Next slide, please. So talking about open fractures, there is limited data in combat-related injuries, but there's good data on civilian prophylaxis in open fractures. So there are certain keystones which both apply in civilian and combat related injuries. It has to be a thorough assessment of the patient and the injury. The debridement, as I stated earlier, is of utmost importance. Stability is one of the key issues. Soft tissue management is of great importance. And of course, antibiotics is one of the keystones of infection prophylaxis. Next slide, please. In terms of assessment, we of course, have to have a look at our patient. Are we dealing with a severe mono injury like this patient? Next slide. Or are we talking about a highly life-threatening injury like this patient sustained? And are we currently in a damage control mode, life before limb, taking care of our patients? Next slide, please. Further assessing the risk distribution to our patients, there is a meta-analysis performed looking at 116 articles, trying to assess the risk factors for infectious complications after open fractures. Next slide, please. And the authors show that there are patient-related issues and trauma-related issues. Next slide, please. Especially about looking at diabetes and vascular disease. Those are relevant risk factors which might not apply always to combat-related injuries, since most of the military personnel is predominantly young and healthy, but nevertheless, to assess the patient on a full scale, it's really, really important to also look at diabetes and vascular diseases. Next slide, please. So within our multidisciplinary setting, it's important for us trauma surgeons to not only look at the injury or the patient from a trauma perspective, but also have different aspects in mind. We always check in every open fracture and every complication, we check for diabetes, and we also check if there could be a vascular problem, looking at the ankle brachial index to have a quick and cheap way to check if there's a vascular problem, maybe influencing our therapy and maybe causing a risk for an infectious situation. Next slide, please. So once we assess our patient, we have to assess the injury. So this is obviously an open fracture. And next slide, please. And what makes this so difficult is usually the soft tissue. This is one of the godfathers of trauma surgery in Europe, Martin Allgöver, one of the founding fathers of the AO. It's a global association talking about dealing with trauma and orthopedic surgery. And he stated that surgery on the bone rarely presents serious problems as long as the soft tissues are in good condition. And the soft tissue problem is therefore paradoxically at the heart of fracture surgery. Next slide. So if we want to classify or assess an injury, there are several classification systems we can use. So one classification system I came across quite often was the one by the Red Cross wound classification, where the patient is classified or the wound is classified by the size of the entry or the exit. If the cavity takes 2 fingers before surgery, if there's a fracture involved, if there's a vital structure involved, or are there still metallic bodies in place. So I think this could work really good for a tactical setting. But if we want to assess the injury and have an individual path of treatment, it's usually, next slide, please. It's usually the classification, old classification by Gustilo and Anderson, which is quite easy to use, but really gives a good estimation of the risk in terms of the open degree of open fracture. Next slide, please. So it's really easy to apply. It's a centimeter below. We're in the first degree open fracture. If the wound is above 1 centimeter until 10 centimeters, we are in the second degree one. And everything that's above 10 centimeters with severe contamination, complex fracture morphology, we're in the third degree. And if there's a vascular injury to be treated, it's also subdivided into at the third degree fracture into the 3C1. Next slide, please. And this classification is really established in modern literature. It gives a good estimation about the risk. There's a direct correlation of the degree of soft tissue injury, as stated by Allgöwer earlier, and the infection rates. And we are talking about, in a civilian setting, of 50 to 70% of infection rate in third degree injuries. Next slide, please. So, since soft tissue is one of the key issues for this classification, and since we are talking about high velocity injuries within this combat related injuries, it's consensus that for combat related injuries, we are mostly talking about a third degree. If a fracture is involved, a third degree open fracture, and therefore it has to be treated accordingly. Next slide, please. Further classifications are in preparation of this talk. I found in the literature, especially from the United States Forces, this clinical practice guideline subdivides combat-related injuries in anatomic regions. If the extremity is involved, if there's a thoracic or abdominal problem, maxillofacial and neck injuries, if there's an injury to the central nervous system, are there eye wounds, burns, or if there's a delayed evacuation. Next slide, please. From the Federal Office of Civil Protection and Disaster Assistance in Germany, there is an analysis in which the stockpiling of antibiotics is performed. And to estimate the need for antibiotics, the injuries, the combat-related injuries are subdivided into ballistic injuries to the extremity, thorax, head, and abdomen, thermic injuries, and explosions. And by classification within these subdivisions, the need for antibiotic stockpiling is calculated. Next slide, please. So the next keystone to infection prophylaxis in open complex injuries is the debridement. You should always go or start the surgery of debridement with a plan. It should be tissue driven. Next slide, please. You should start with the skin, go to the fascia, the fat, the muscle, and the bone. Should take microbiologic samples. Next slide, please. You should use a lot of a solution with low pressure, and there a lot of solution is useful since we want to have a reduction of the pathogens. Therefore, a dilution is what we are planning to achieve. and especially in highly contaminated injuries like this injury right here, a redebridement has to be performed maybe the next day, sometimes also within 12 hours or 2 days, depending on the severity of contamination. Next slide, please. Yeah. So the debridement within the shaft should be seriously performed. We should remove the loose fragments, foreign bodies within the joint. It depends on the degree of contamination. We have to debride the fracture ends, and the mechanic cleaning has to be performed. This debridement should be serious. Next slide, please. Since I would really prefer a defect over an infect, since, as I showed you earlier, there are several ways to reconstruct bone loss once the infection is resolved. Next slide, please. This debridement has to be performed really early, especially in high grade or severely contaminated fractures. For every hour we are waiting with debridement, we gain a risk of infection by 3%, as stated by these two publications. Next slide, please. Next key issue is stability. Really important. Several factors are influencing the way to gain stability. The anatomic region is influencing the amount of stability we need. How is the contamination? How is the size of the wound? Is coverage of an implant, if we are talking about internal fixation, possible? And of course, if we are talking about tactical settings, how are the resources? How is the infrastructure? How is the personnel available to provide stability in terms of surgical interventions? Next slide, please. So for first degree open situations, internal fixation is of course possible. Also for second degree open fractures, in third degree open fractures, it's predominantly recommended that you should use a fixator external. Next slide, please. And especially looking at combat-related injuries, these guidelines by the United States Forces strongly recommend the use of external fixators to allow stabilization during long evacuations. It's easier to observe the wounds, easier over the use of a plaster, and it's just potentially less infections that occur if you use an external fixator. Next slide, please. So this is a case in which these keystones for prophylaxis of fracture-related infections worked really well. This is a young patient, a third-degree open fracture, as you can see here. He sustained this after a motor vehicle accident. Next slide. So we debrided, removed a lot of loose body fragments of the shaft. We applied external fixator. We used solution to dilute the number of pathogens. Next slide, please. And we also shortened the leg slightly to have some to relax the soft tissues. Next slide. And after soft tissue treatment, 20 days later, it was able to change to an antibiotic-coated intramedullary nail. As you can see here, we regained the length of the limb with a plate on the fibula. And as I mentioned earlier, I would rather have a defect than an infect or an infection. Next slide. Since we are able with work, especially done by Elizarov, to regain bone in bone defects. Therefore, 30 days later, a corticotomy was performed. We applied a ring fixator. Next slide, please. And by 1 millimeter a day, the bone segment was transported over a nail until docking. Next slide. So this is the docking that happened. We see the circle above, the regenerate, and we see the circle beneath the docking zone. Next slide, please. This is the picture of the patient with the ring fixator. Next slide, please. And after docking, we fixed the bone segment that was transported by a medial plate, as you can see here. Next slide. And 9 months later, this young patient with this limb-threatening injury was able, by performing the keystones that I mentioned, and thorough debridement, was able 9 months later to go back to work, as you can see by his working boots, and was able to work full-time as a carpenter. Next slide, please. So soft tissue management is also really, really important. We are really, really happy that we currently, or like 2 or 3 years ago, we got a plastic surgeon and his team to work at the department. We are here at the University Hospital in Münster because there was a real lack of plastic competence around here. So since then, we are able to treat our open fractures much more frequently and much quicker with the thorough soft tissue management, since we know that primary or early wound closure reduces the risk for infection and non-union, not only as stated by this publications you can see here. Next slide, please. If we look at soft tissue management in combat-related injuries, here are the guidelines again from the United States Forces. There's a strong recommendation to close wounds not too early, but the recommendation is that the typical closure of a wound, a combat-related wound, should be within 3 to 5 days after injury, what I consider still as quite early. Next slide, please. So the most challenging topic when talking about combat-related injury is probably the way antibiotic application should happen. What's not really complicated is that it should be as early as possible. It should be applied within the first 3 hours. After that, we have an increase of risk of infection by up to 7%, according to these authors. Next slide, please. The duration is also pretty much the same, looking through the literature. Within the first and second degree open injuries, 24 hours of antibiotic application should happen. For third degree injuries, third degree open fractures, it's mostly 3 to 5 days. Antibiotic treatment should be applied. After 5 days, it's more or less, it has a negative influence in terms of increasing resistance strains. Next slide, please. So one aspect where literature is currently lacking is, but I would really like to emphasize, is the local application. Um, this systematic review by Morgenstern et al. Was able to show that by local application in open fractures, no matter what, if you use a PMMA spacer, if you use local application of powder, if you use antibiotic coated implants, altogether it's calculated that you're able to reduce the risk for infection by 11%, which I consider is a really, really high risk reduction. And therefore, we are highly into local application. In open fractures. Next slide, please. So, but especially looking at combat-related injuries, it's really, really challenging to answer the question which antibiotic we should use. Next slide, please. So we know from the civilian literature that we are usually dealing with gram-positive pathogens within the first and second degree open fractures. But if we are looking at high degree open fractures, if we're looking at third degree open fractures, highly contaminated fractures, it's not only the gram-positive spectrum we have to deal with, but it's also a polymicrobial pathogens and gram-negative pathogens which we have to deal with. Next slide. So within our multidisciplinary setting, and we have a really, really great cooperation with our antibiotic stewardship team. We have our standard for open fractures, as you can see here. We are using in every open fracture ampicillin sulbactam for first and second degree open fractures for a max of 24 hours. And in third degree open fractures, we use these antibiotic IV agents for 72 hours and additionally apply vancomycin as a local antibiotic powder in the wound. Next slide, please. Looking through the literature, there are several recommendations which vary quite a bit. So this is one of the recommendations from the United States Forces, where they divide the recommendation whether or not it's grossly contaminated or not in an early control setting. So if we're early controlled, we are mostly dealing with gram-positive pathogens. Therefore, the United States Forces recommend the use for cefazolin 2 grams per every 8 hours for 1 day until coverage. If it's grossly contaminated, the application or the addition of metronidazole is also recommended. If we are talking about a delayed evacuation, a tactical setting, the recommendation within this practice guideline also recommends the use of moxifloxacin as a single dose within the tactical setting. Next slide, please. Again, looking at the German recommendations, if we are looking for a standard treatment, the antibiotic agent recommended for combat-related fractures is ampicillin sulbactam. If it's grossly contaminated, there's a shift to piperacillin and tazobactam with the addition of clindamycin. Looking at the French recommendations and the UK recommendations, they are predominantly working with amoxicillin and clavulanate. For the French for 24 hours and the UK for 3 days. Next slide, please. And again, I would like to highlight the use of local application. There's not good literature and there's no consensus for local application, especially under orthopedic trauma surgeon. There's no consensus of what to use, how to use, and how much to use, but we still think that there's a good benefit of local application. Looking at implant coating. Next slide, please. Looking at implant coating, there are several ways to apply local antibiotic treatment as implant protection. One I'd like to mention is the gentamicin coated nail, which is useful in trauma. Other ways of coating are mostly with silver. Next slide, please. With the high dose or low dose silver. Next slide. Or other coatings. Next slide. Next slide. Yeah, keep going. But those are mainly only for orthopedic purposes. Another aspect which is able to provide local antibiotic implant protection is a hydrogel, which can be used with different antibiotic agents. Next slide. But again, the literature is not really good on local application, and therefore the guidelines for combat-related injuries is still that there's no recommendation for local application. Looking at the paper by Nasser et al. From Medical Missions to Gaza, they highly recommend the use of gentamicin and vancomycin loaded bone cements as a local application. But the biggest problem is that there are so many differences in local antimicrobial flora. The injuries are highly inhomogeneous. There's no standard, no global standard for antibiotic treatment in combat-related injuries. It's always with local considerations that has to be performed, looking at the local situation, and the doctors and the nurses have to deal with. Like this next case. Next slide, please. So this is a case from our department. It's a young Ukrainian soldier. He was referred to us within our Solidarity cooperation. And in this case, the keystones I mentioned earlier, especially also the local application of antibiotics within this PMMA, worked really well. Next slide, please. So this young guy, he sustained a shrapnel injury, thoraco-abdominal, that damaged the left lung. There was a penetration of the heart with hemopericardium. He had a gunshot to the pelvis, which caused a defect at the intertrochanteric part, a lesion to the ischiatic nerve, and he had multiple grenade fragments. So the doctors and the nurses in Dnipro did a great job in saving this guy's life and also the limb. They applied, next slide, please. They applied all the keystones of treatment. They debrided, they stabilized, they applied antibiotic PMMA as a local treatment. Next slide. So when he was referred to our department, it was mainly the defect of the intertrochanteric part we were asked to take care of, and also the lesion to the ischiatic nerve. Next slide, please. So he presented with the X-rays you just have seen. He had a skin flora with a multi-resistant gram-negative spectrum. He was presented in our multidisciplinary board. We were advised to revise the defect site. We took samples of the bone defect. We did a neurolysis of the ischiatic nerve, and we removed further grenade fragments. Next slide, please. So due to the skin flora and our experience with fracture-related infections coming from Ukraine, we highly suspected a fracture-related infection with coming from the multi-resistant gram-negative area. So after talking within our multidisciplinary board, we applied Cifidecerol operatively. Next slide. But as we found out, it was not really necessary since the microbiologic samples we took from the wound were without pathogens. So we were able, since there was no signs for infection, no confirmatory signs, we were able to perform the defect reconstruction. I've performed a shortening of the femur to bridge the defect with a blade plate. Next slide, please. In complex cases, especially when there's still a rest defect, we are able to perform a 3D print of certain cases, as we did here, and we saw that there's still a significant defect at the intertrochanteric part, which would probably not last too long if we would not reconstruct these defects. So again, multidisciplinary board with our plastic surgeons. Next slide. And we planned to use a vascularized fibula transplant in this patient. As you can see on the left side, the resection of the fibula, prepared it to fit the defect at the proximal intertrochanteric part. Next slide, please. Then we did the anastomosis to the femoral artery, additional plating for the fibula fixation. The lateral blade was from the initial shortening. Next slide, please. There you can see the postoperative X-ray. Next slide. With the fibula graft, the additional plate for fixation, and the lateral blade. Next slide, please. So this is the CT scan after 3 months post-operative. We see good consolidation. So we are able to, next slide, please. So we are able to take care of the leg deficiency of 12 centimeters. The plan is to implant a retrograde motorized lengthening nail. We're going to perform an osteotomy at the red line you can see below, and then the callus distraction of 12 centimeters is the plan. Again, keystones are really, really important. If we are talking about highly complicated pathogens or, let's say, combat-related injuries, debridement is one of the key issues we have to address. And again, I'd rather treat a defect than the infect. Next slide. So in summary, it's really, really important to assess the patient and the injury. We have to look beyond trauma. The keystones in treatment have to be followed, defect over infect. We have to keep local application in mind. Standard procedures like gloves, gowns, and the isolation of early and delayed wounds, I did not emphasize in this talk. but I think that should be a standard treatment. The antibiotic treatment in combat-related injuries is highly complex. It should be standardized and it should address, especially in the early situation, gram-positive pathogens, late or gross contaminated. There's a shift to the gram-negative spectrum. The most important aspect in terms of antibiotic recommendation is the regional assessment of the microbial flora. Also, seasonal changes can cause differences in the pathogens you encounter in these wounds. Next slide. It's really important to know your infrastructure, know your partners who help you treating these complex injuries. The plastic surgeons are a great help for us in treating these patients. We are strongly cooperating with our antibiotic stewardship team and the vascular surgeons. And I can highly recommend that some sort of interdisciplinary board is implemented in areas where you have to deal with these injuries. It does not necessarily have to be at the place you are treating your patients, and it can be digitally provided, but talking together about complex situations, it's gonna make each other much better in treatment. And sometimes also, let's say, to talk about situations where you not feel happy with, but your partner tells you that you did everything that was necessary to do, sort of even in situations where you're not happy with the result, can cause a relief to your situation. Next slide, please. So I would really like to thank you for your attention. I'm really sorry that due to the technical issues, it was a bit difficult for me to have on one monitor the English one, and then Sarah was so nice to speed up or to change the slides. But I hope that I was able to give a short insight on this highly complex topic. I'm really thankful to be part of the program, and I hope you stay safe. I'm really happy to answer some of your questions, and thank you very much for your attention.
Дуже дякую, професоре Штефане, за вашу
Thank you very
доповідь.
much, Professor, for sharing with us
Дуже цікаво, матеріал дуже
this
цікавий
very
і, на
interesting
жаль,
subject.
актуальний для України зараз.
This is very
Впевнений, що
interesting and
нашим
unfortunately very
колегам
relevant for Ukraine.
була тема
I hope our
дуже
colleagues
доцільна та
were
цікава також.
very much
Враховуючи,
interested.
що ми вичерпали
And since we
наш
have
час, я хотів
exhausted
би
our
попередньо
time,
уточнити у вас,
I
пане
would
професоре,
like,
чи
first of
є
all,
у
to
вас
ask you,
можливість та час
Professor,
відповісти на запитання?
can you answer questions right now? Do you have time for that?
Of course, yes.
Чудово.
Great.
Дуже вдячний за
Thank you.
таку можливість.
Thank you very much for an opportunity. There are a few questions in the chat. I will read them. The first question is, I think it's very much practical. People are asking, what solutions do you use during debridement?
Well, we mostly use Ringer lactate. Is that the right translation?
Yes.
Yeah. So it's mostly warm Ringer lactate we are using. It's mainly it's the cheapest solution, the cheapest sterile solution we are using to debride these open situations.
Дуже дякую за вашу відповідь, пане
Thank you
професоре.
very much for your answer,
Запитують
Professor.
щодо
There are
мікробіології.
some other questions
Як з
about
вашого досвіду, які
microbiology.
мікроорганізми
From your
найчастіше
experience,
викликають
what
гнійно-наземельні захворювання при лікуванні
microorganisms
бойових травм?
cause inflammations most frequently in combat injury? And what is the percentage, if you remember, what is the percentage of resistance of these microorganisms?
Well, again, combat-related injuries, it's such a big topic. It's quite different if we're talking about pathogens in, let's say, Africa, in conflict areas in Africa. They are different to combat regions or like conflict areas in Gaza or in Israel. And of course, in Ukraine, there are again other pathogens. It's really, let's say, according to the local microbial flora, the patients. So the patients that come to our hospital from Ukraine are mostly we have highly resistant gram-negative pathogens, or we have big defects or big, let's say, plastic defects skin defects that we have to treat. So I think I have a bit of a non-objective way of looking at these pathogens because the patients I see, it's 90% of multi-resistant gram-negative bacteria causing these problems. Yeah, so that would be my answer to that.
Дуже дякую за вашу відповідь.
Thank you very much.
Питання також
The next question is again about microbiology, and people are asking, what is the duration of antibiotic treatment of resistant flora?
In terms of wounds, like if I'm treating antibiotic in an antibiotic manner, open fracture, or what? Did I get the question right? Okay, so if the question is, so I'm a trauma surgeon. I have to disclose that, okay? So if we are talking about the treatment of the skin flora, I think there are people who have much better knowledge in this topic. But if you ask me if I have a patient with a resistant skin flora and he has also an open fracture, it would not change my my management. The most important thing is debridement, the solution to use, the dilution, stability, and early soft tissue closure. For antibiotic treatment, from the recommendation I have from the German Federal disaster, hold on. For the Federal Office of Civil Protection and Disaster Assistance, there's a recommendation for piperacillin and tazobactam. And if we are talking about, let's say, open fractures, it's 3 days.
Дуже дякую за відповідь, пане професоре. Я погоджуюся.
Thank you very much. I would agree that every case is individual, is specific, and we need to use individual approach to the patients, especially when we're talking about resistant flora. The next question is about local application of vancomycin. The question is, how can we use vancomycin locally because there are some studies which prove that it's not effective in vitro.
Well, I know there's literature of in vivo use of vancomycin powder, especially in treating spinal situations, spinal surgeries. We, in every revision case, in every open fracture, we use vancomycin powder, and we apply it directly on the implant or on the bone. There is there's a big randomized controlled study going on. I think the name of the trial is called Powder, where they look at application of vancomycin in open fractures. So, but I think the study is still running, so they're not able to present data yet. But yeah, we have a gut feeling that it is useful. We know by the systematic review by Morgenstern et al. That local application has a beneficial effect. And therefore, I mean, we're not talking about a small finger fracture. We are talking about mostly third-degree open fractures. We are talking about injuries where the limb is at risk. So I'm more than happy to take every measure to save this limb. And usually, I think that applying vancomycin powder could provide some beneficial safety in terms of infection control.
Дуже дякую за відповідь, пане професоре.
Thank you very much, Professor, for your answer. I also remember how you stressed in the presentation that there are certain debates with regard to local administration. So this is a debatable question as far as I understand. And I see we have the last question because we are behind the schedule. Very interesting question. What would you recommend with regard to treatment of a patient with a multiple trauma and with inflammation in his wound? And if microorganisms are not susceptible to antimicrobial?
So it's multi-resistant, or is it a early wound?
Так, все вірно. Мікроорганізм мультирезистентний.
Yes, the microorganism is multi-resistant.
Okay. Well, so so we are treating a wound infection in a polytraumatized patient with multi-resistant pathogens. Is that correct?
Так, пане професоре, все вірно.
Yes, that's right.
Okay. So, well, thank God we have an antibiotic stewardship team, which will tell me what type of antibiotic to use. In this patient, I showed you from the Ukraine, the young soldier, where we highly suspected FRI with a multi-resistant gram-negative pathogen. Our antibiotic stewardship team recommended, since there are genetic changes due to the within the pathogens we sampled from Ukrainian patients within our hospital, that the cifidérocol, like it's a fourth generation cephalosporin, is effective in these patients. But whenever there's a patient I want to treat, I at first want to identify the pathogen. I want to know what's the resistance situation, and then I have to check what is available. I mean, we also there are not every time every antibiotic available, especially in a tactical setting in a conflict area. Not every antibiotic is available. We should use, if we know the pathogen, we should use the most narrow spectrum antibiotic we could think of. Um, but it has to be, again, as you said, it has to be if we know the patient, if we know the pathogen, it has to be individualized, keeping in mind that there are also the other wounds that the patient might have. So again, it's an individualized plan, especially in these highly complicated multi-resistant wound infections.
Дуже дякую за відповідь, пане професоре. Я вибачаюсь, наскільки я розумію, чомусь зник переклад, тому я не впевнений, що ви чуєте мій переклад. Mr. Professor Stefane, do you hear translation right now?
No, I do not. I'm sorry.
Okay, it's no problem. As I understand, unfortunately, we're not able to hear translation. Right now, I will translate and wrap up the presentation. Шановні колеги, я вибачаюсь, технічні проблеми щодо перекладу. Якщо
Sorry, I was kicked out of Zoom.
відповідь професора Штефана, він акцентував увагу на потребу в, знову ж таки, визначенні збудника, навіть якщо він мультирезистентний, нам все одно треба розуміти профіль резистентності, звернутися за допомогою до бактеріологів, тому що ми не забуваємо, що навіть при полірезистентності мікроорганізму комбінація антибактеріальних препаратів може дати позитивний ефект. І щодо цього вам може допомогти та проконсультувати бактеріологи, в тому числі вони можуть поставити тести на синергію, які також можуть бути дуже корисними. І знову ж таки, ми не забуваємо, як було надано відповідь на попереднє запитання, схоже, про важливість правильного ПХО, дебрідменту, очищення та закриття рани, коли буде така можливість. Знову ж таки, дуже дякую всім слухачам, учасникам та дуже
So let
дякую
me thank
пану
all the
професору за
participants
таку цікаву та
and let
змістовну
me thank
лекцію. Ми будемо
Professor
завершувати.
Rosalind Breuer for a very interesting lecture.
Враховуючи певні технічні
Now we're
моменти, ми
going
зробимо все
to
можливе
close our webinar,
і спробуємо
and
викласти
due
матеріали
to technical
відеозапис
issues,
на
we will
YouTube-каналі
try
Центру громадського
to
здоров'я, тому очікуйте їх.
publish the recording
Також
of this
нагадую,
lecture
що цей
at
цикл
the
вебінарів
UPHC
буде
website.
продовжуватися.
And let me
І
remind
записи
you that this
попередніх
cycle of
зустрічей
webinars
ви
will
можете знайти на
continue,
YouTube-каналі
and you
Центру,
can
тому
also
слідкуйте
find the
за анонсом,
previous
підписуйтеся на
recordings on
інформаційні
our
ресурси Центру
website.
громадського
So please
здоров'я.
subscribe to
І
information
знову ж таки,
resources of the
бережіть себе.
UPHC. Take care
Хотілося
of
б висловити
yourselves.
вдяку нашим міжнародним
And I
партнерам,
would like
ще раз
to
висловити вдяку
thank our
професору,
international partners,
CDC та ICAP
to
Колумбійського
thank
університету за
Professor,
організацію цього заходу.
CDC,
Всім
ICAP,
гарного вечора
Columbian
та мирного
University.
неба.
Everybody have a nice evening and a peaceful sky.